Hello, and welcome to another episode of the Melbourne Athlete Development Podcast. Today we have with us orthopedic surgeon Dr. Janan Chandrananth. Janan, thank you for being with us today.
Thank you for having me. It's my pleasure.
I hope I got the name more correct this time.
Oh, yeah, you did very well.
So, to begin with, do you want to introduce yourself? Just to give us a background of who you are, what you do, and we'll start the conversation from there.
Yeah, sure. My name's Janan Chandrananth. I'm an orthopedic surgeon. I'm a Victorian, Welsh-born, and I'm mainly specializing in foot and ankle surgery. I did my training here in Australia and moved around as part of that.
Great. So I know as a part of your training, you've done quite a bit of travel and you've done a fellowship over in Japan and over in the UK. In addition, you've also done some training, I believe, earlier in your career over in the States. And I think it's always interesting to discuss and explore how your exposure and experiences in different countries influences what you do now clinically, but also just some of the observations you've made with regards to differences in the healthcare system. Because I know, and I think I mentioned this to you briefly offline, I'm currently doing a training program over in Italy, and I've had the opportunity to meet a lot of different clinicians, both physiotherapists, chiropractors, medical doctors from different parts of the world. And it's amazing to see how many differences there are in terms of what they do, but also in terms of what they're taught through their tertiary education. So, what are some of the experiences that you've had with your training in different parts of the world?
Yeah, sounds good. Sorry, there was a bit of a lag there, but I think I caught most of that. Yeah, I mean, it's I've been fortunate enough to be able to travel as part of my training and going to all these areas. It's been amazing to see how the different places, while treating people effectively, have such a difference in how they approach things based on cultural, practical, and economic factors. And it gives you a wider perspective of how to treat patients back home. Because I think in Australia we have a great healthcare system, and by comparing it with the benefits and the flaws in other areas, you get a more balanced approach to how we do things back here.
Mm.
So I think in terms of Japan's such a unique place, and I love Japan because it seems like a environment unto its own. It's gone on its own track. It has a very unique culture. The language barrier is certainly there. Not many people there have a good English literacy, so there's not much in terms of literature that comes out of Japan. It's mainly published within the country.
Mm.
And in terms of their demographics, they have a huge rate of ankle issues because they have a high rate of tibia varum. So they're bowed-legged in terms of most of the Japanese
And is that
population.
a genetic
So
variation?
yeah, it's a genetic variation, and it's I think higher in Asians in particular, but it's noted in Japan. And interestingly, there's also a high proportion of orthopedic surgeons in Japan, and a
Mm.
lot of the classifications for ankle arthritis come from Japan as well. So that's why it was great to go there and see what it was like.
Is that one
And
of
in
the
terms of the
reasons you
culture in
chose
Japan,
that? Sorry, is that one of the reasons you
yeah, I
chose
guess
that?
yeah. After reading into it a little bit, that is one of the reasons I chose that. That to be honest, I'm a bit of a weeb. I love Japan and the culture and the people, and I did Japanese at school, so that was my main foray into thinking about going there. And when I looked into it, there was a lot of good foot and ankle work getting done there, so that really pushed me over the edge in terms of going there.
Just out of interest,
Um,
has there been any explanation for why you see that genetic variant in Asian population, specifically in Japanese, why they have a high prevalence of tibial variant?
Yeah, in terms of the genetics, I'm not too sure myself. I know they do have a lot of kneeling activities, bending over activities. I don't know if this faces more of the mechanical load through the medial aspect of their tibia, causing them to bow. But I guess that would be an element of epigenetics with activities and behaviors influencing the genetic expression over a long period of time. But it's a good question. I'm not sure exactly why that's the case. They're also shorter statured people,
Mm.
and I do tend to see people who are a bit shorter tend to have more bowed-leggedness. But the exact genetic association, if it's been pinned down to a gene sequence, Not sure if that's been found yet, but certainly an area for further research.
Yeah, yeah. Were there any other particular things that you noticed that were different with regards to the training of, say, orthopedic surgeons in Japan, or even, say, the management, like around post operative management in the Japanese healthcare system that's different to Australia?
Yeah, I mean, from a economic point of view, first of all, they have a very social healthcare system where the government, even in private hospitals, pays, I think, for the majority of healthcare, and then the patient pays, I think, 20 to 30%, and it's based on the number of hospital day stays and the procedures they have. And in terms of the training, it really seems to change depending on which institution you're at. So in the area my supervisor was someone who's been around for a long time, and he was trying to do a few more less common things. And when I talk to other surgeons there, they'll be saying usually at the bigger hospitals, they'll be tending to go with the Western culture of higher rates of immobility post-operatively. Whereas at this hospital, are finding we're getting patients weight bearing after most procedures straight away. And in terms of the training for surgeons there, it was a similar sort of system from what I could see, but there was a lot more of choice in terms of where these surgeons would go and try and get further experience in the area of their field that they wanted. So while I was working in an area in Koshigaya, did have a few traveling trainees come to see what my professor liked to do to learn a bit more about his corrective osteotomies and how he did his surgeries.
Mm.
And it's also, I guess, very much uh, based on training from doing. I think they do also do sort of general orthopedics and then go into more specific specializations um, towards the end of their training. Whereas places like America, they find their subspecialty focus very early, so they don't get that general orthopedic experience as much.
With that in mind, Janan, what brought your interest to the foot and ankle? Why specialize in that area?
Yeah, I mean, it's funny. I think we were talking about this before that when I first started training, I thought foot and ankle and spine were things I weren't going to do. But then as I went through and I had more mentors at each of my rotations every 6 months, I was fortunate enough to have a senior colleague who was well versed in foot and ankle. And I saw how much variety there was in foot and ankle. And not to downplay my colleagues in hip and knee, I just found that the if you're a hip surgeon, your day was mainly spent doing hip replacements, which have great patient outcomes and are really helpful for getting patients pain free. And the same for knee; it was knee replacement, ACLs, maybe meniscal pathology. Whereas in foot and ankle, every list was different. There would be one list with lesser toe and great toe pathologies like bunions and great toe arthritis, another list with hindfoot corrections and ankle arthritis, another one with flat foot or cavovarus foot, deformity corrections, tendon transfers, Morton's neuromas. So I just love it that there's so much different pathology in the foot and ankle, and it keeps you challenged and keeps the variety going so you don't get bored every day.
Hmm. You know, one thing I think about with the foot and ankle, and is the prevalence of OA is not as high as in, say, the knee and the hip, and we're obviously having a lot of issues where there's an increased prevalence in osteoarthritis in general. But it's a question John and I have asked ourselves and discussed before. We see a lower prevalence of osteoarthritis in the foot and the ankle, which from a mechanical standpoint doesn't really make sense because it would be experiencing larger
Exactly.
mechanical loads. Is there any explanation for why there is a lower prevalence of OA in the foot and the ankle compared to the knee or hip?
Yeah, I mean, it's a good question, and it made me think of doing my basic sciences exam and thinking about biology of certain chondrocytes in parts of the body.
Mm,
And you're right. I mean, in terms of the ankle cartilage itself, it takes the greatest per force per unit area of cartilage in the body. And despite that, in the body itself, it accounts for in the population about ankle arthritis about 2% of the arthritis load, and For the great toe, which is the highest prevalence, is about 5% compared to hip and knee, which is the vast majority. And there are a couple of sort of structural factors and biological factors that are thought to be a reason for this. So the ankle cartilage is thinner than that of the knee, but it's much stiffer. And because of that, it's more resistant to shear forces and cleaves within the cartilage structure itself. The cartilage is also more anabolic. It's more metabolically active than cartilage within the knee. And it creates proteoglycans and osteogenic proteins, which are the building blocks for creating connective tissue. And when we do microfractures, we find that it's more successful in the ankle as opposed to the knee because it creates cartilage more readily.
Do we know why
We
that
know
is?
cartilage regeneration in general. Yeah, so we're not 100% sure why this happens. Like, we know, I think it's a great area for research. I think if we could find out why this ankle cartilage has a different structure, has the ability to signal for certain factors to be created to aid in repair, potentially that's an avenue to look at uh, cartilage repair mechanisms in other parts of the body. And by the same token, in the knee, there's a higher, for some reason, I don't know why, but they have a higher rate of enzymes that actually break down cartilage over time. I don't know why the body has that and what the reason is. But when there were studies looking at the ankle itself, those factors weren't found. Um, and then you get the reflection in our population with ankle arthritis. The people who get it are much younger. So you find they're less than 45 years of age. You tend to have more people with ankle arthritis. Whereas hips and knees, as you know and you see, they're older people. So degenerative component of of arthritis in the ankle is very low, but the traumatic component is high. So ankle arthritis generally happens after an ankle fracture or recurrent sprains and ankle instability, which is
Do,
a recognized
do you
cause.
do you think that that could be related? Like, it's becoming very clear that arthritis that we see, particularly around the hip and knees, very much related to the metabolic health of that individual and potentially sort of some ongoing systemic inflammatory input. Whereas, from what you're describing, that sounds like ankle is much more associated actually with the mechanical loads experienced, and for that reason, we see it in those different populations versus, ankle much younger and healthier, but potentially, as you said, have had traumatic changes. Versus someone who is older and maybe hasn't actually taken on that many mechanical loads over time, or it's to the same magnitude, but actually their overall health isn't that great, and they're actually leading to degradation of those joint structures.
Yeah, I mean, it's interesting. Yeah, there's thoughts about the inflammatory process that leads to that cartilage degradation. But yes, I think in the ankle and in the older population, you don't have as much of that mechanical shear force on that ankle, which is why it's seen in that younger population.
Mm.
But I'm not
Just to
in terms of the hip and
feed
knee.
on John's point, something that I once thought of and I forgot about it until John actually reminded me of it in a podcast recently is when you think about osteoarthritis, we have to appreciate that it is a very much a systemic problem. People often associate it purely with like mechanical degeneration, and obviously mechanical factors can be a factor, particularly if you've had traumatic injury to that associated joint. But the other thing that happens and is more prevalent now in society is fat mass. And when you think about fat mass
Mm,
distribution, it does vary obviously from males to females, but you do see a lot more fat mass around the hip and potentially the knee. And I know there's a study I came
mm.
across a year or two ago which showed that there was an association with more fatty infiltrate in the quadriceps, particularly distally, being associated with knee osteoarthritis, which made me start to think of, is there even a potentially localized effect with the joint metabolism associated with the amount of fat mass? And when you think about the ankle, typically there's not as much fat mass that develops around the foot and the ankle compared to the knee and the hip. Does that seem plausible or rational, or have you actually read anything that further supports that idea?
Yeah, that's an interesting thought process. I mean, cankles are a thing, but very rare, and it'd be interesting to see if patients with cankles, if they did have higher rates of ankle arthritis.
Mm.
But yeah, very very possible. I mean, every sort of um, every sort of breakthrough that we make in medicine and in healthcare is made by some sort of observation, and then we try and go through rigorous testing and to see if that's actually plausible. But I think it's very possible. I mean, a lot of people hold their adiposity around their hips and their knees, and I guess also around their central adiposity. It might relate to the spine as well.
Mm.
I'm not too sure, but yeah, very very possibly there could be cytokines and other chemical agents that are released that cause your joint to react to those. But by contrast as well, I do see a lot of people who are reasonably lean with horrible arthritis, and I think being in the position I'm in, I do see patients who are already sub-selected with arthritis. They come and see me, so potentially compared to the rest of the population, it's not really that significant. But you do see patients with severe levels of arthritis who don't have that much adiposity in those areas. But I think it's worthwhile looking into. It's not something I've read myself.
The other thing that makes me think of, Jack, is whether, because walking, typically most of the propulsion actually occurs at the ankle. If you look at the biomechanical breakdown of hip, knee, ankle contribution, is there some sort of benefit that we get just by general, walking and locomotion, that
Yeah.
over time we don't get the same benefits because the knee and hip is not being used?
But because that's the thing I think of too, when you mentioned before, Janan, about the difference in the cartilage thickness and stiffness of the ankle versus the knee and hip, is it's a thing I think of straight away. Is like, why is that the case? Like, there's always, an evolutionary explanation for it. And I wonder if it's related to that, and perhaps even more so now with um, more sedentary behavior, even at a younger age, whether you're getting a lack of adequate cartilage development and stiffness in the knee and the hip, because most people are limited to doing walking and low intensity type of activities that don't put a high load through the knee or the hip through those
Especially through
developmental
range.
periods. Yeah.
Like, I think the ankle is typically asked to work through lots of range. Even think about going up and down stairs,
Yeah.
uneven surfaces, different, like different positioning. I think it's very different to what happens at the knee and the hip in general day-to-day life, unless you are
I think there's a lot of merit to that as well. Yeah, for sure.
who knows?
Yeah,
It's
agreed. I
obviously not
think
substantiated.
it's similar, I guess. Yeah, but you do see the same thing with the bone. Like the more you use it, the more stress you get through it, the more trabecular you make with Wolff's Law. And I think a similar thing could be happening with cartilage. And given that the ankle is a bit more of a confined joint, you can go reasonable amount of plantar and dorsiflexion, but the eversion inversion is not that much, so it's more constrained. Versus the knee, where you have the screw home, you got a lot of shearing, going side to side with various valgus and deep flexion. You don't get that same amount of stress that propagates to all parts of the cartilage, which might mean there's some areas that are more prone to injury.
Well, and actually, I think that's
So
highlighted
yeah,
too when you think, Janan, about the complexity from an anatomical standpoint of the foot and ankle, because there's clearly a lot more joints involved that almost have a lot more specialization in terms of where certain movements in different planes happens, and perhaps that's actually like, well, clearly it may be an evolutionary an advantage, because it mitigates the abnormal, say, shear stresses that can potentially occur at the knee, because of the fact that all the load through the kinetic chain when it goes through the knee is only happening in one joint.
yes, that's right. Just distributed all through that fairly evenly.
Yeah. I was interested to go back to thinking about differences you've seen in the healthcare system and through training. And one of the things that you mentioned before was, in Japan, typically the things that influence what they do is literature that's been published in Japanese. And I think about this a lot of the time, where we are limited to only, well, for myself personally at least, limited to only reading published research in English. And some of the limitations that we have when you have publications happening all around the world in different languages. Did you find in your experience, and perhaps even because it sounds like, I'm assuming you speak quite good Japanese, that you're exposed to a lot of literature that influence what you do clinically, being able to read it and actually use that into your clinical practice?
Yeah, I mean, in terms of my Japanese, it's reasonable, but I'm not at that fluent level where I can read it comfortably. But
Mm.
the good thing about even in our modern age, technology helps us bridge that gap.
Sure.
So while I was able to converse easily with in Japanese, sometimes if there was difficulty in reading something, I'd whip out my phone, put
Mm,
on Google Translate,
yep.
and it was quite accurate in terms of translating what was there. Sometimes a bit broken, but seeing how the practice in Japan was, and then trying to read back to see why they did those things based on some Japanese literature is quite helpful. And that's helped me bring a few techniques over from there that I would never see back home.
Mm,
I guess an example is calcaneus fractures. Standard of care here is that if you break your heel bone, you essentially have to rest in bed for 2 to 3 weeks. I wait for the swelling to come down because there's a high rate of skin necrosis once you go through that swollen tissue, and then eventually fix it once the swellings come down. But the swelling is there because of the anatomy being abnormal, because of the fracture being in a poor configuration. So in Japan, there's a publication done a while ago by someone called Omoto, and he would be doing a close reduction as soon as someone comes in. And because the ligaments are intact, you can put traction and and heel movement from side to side, and then that would drastically improve the position. The swelling would generally improve within a couple of days, and then you can operate on them much sooner. And I found doing that now has really helped me with getting positioning of the fracture better before even making a cut. So just little things like that, and in different facets of what I found in Japan has really helped at least broaden my thought process. Like that's something I'd never think about before going overseas.
mm,
So like even before going overseas, I thought, oh, why do I really need to go overseas? Some people say it's not really needed. The Australian orthopedic training program is pretty good. You're pretty confident when you operate after finishing compared to other people around the world. But you don't get these perspectives, these different ways of looking at things and experiencing healthcare systems, which will, I think, make you a bit more well-rounded in terms of your decision-making processes.
With that in mind, as you've gathered knowledge from different areas of the world and you've implemented that what you do clinically, have you found resistance with implementing some of these new ideas coming back to Australia, or do you find that there is a good amount of openness and receptiveness to these new techniques and interventions that you've learnt?
Yeah, I mean, it's a good question. And I think in private practice, it's a bit easier because you're talking to a patient, you're giving them
Mm,
the evidence and literature and your perspective, and you're giving them the pros and cons. Whereas in public, there's a lot of cultural reasons why we do things, and the cultural reasons do change from place to place. And I think a reasonable example is, I guess, in the UK, because the NHS is very stretched, they have to make every pound work for them. So they've done big studies, big multi-center studies looking at distal radius fractures and determining how to fix them. Is the best way with a plate, is the best play with just with a closed reduction and wires. And they found that the results between wires versus a plate are very much the same in terms of functional outcome. Whereas I found here in Australia, we tend to do more plating because it makes the anatomy more normal, and it doesn't really change the outcome, but that's the culture that we've been doing here. So I certainly, going through different places, found some places more receptive and other places were just saying, no, that x-ray looks horrible, it doesn't look perfect, so it's the patient, we should be fixing it with a plate and screws. Whereas the literature and the experience in another country would be saying the vast opposite. So I mean, ultimately, it's about balancing out, I find, the outcomes. If the outcomes are going to be about the same, the risk profile is not that much different. I don't find much point in arguing and making that much of a hullabaloo about it. But if I find there's something that makes a huge difference, I think that's something I would be more likely to push a bit harder, if that makes sense.
mm, mm,
Well, it's interesting because you mentioned it earlier, the idea that particularly in Japan, because they enjoy precision, they're looking to really
Mm,
maximize on the anatomical alignment that you get in surgery. And a question that I had,
mm,
because it's something that was mentioned to me by an orthopedic surgeon, is how much evidence actually is there for emphasizing that? Because whilst it's something that continues to be sought after, and I know Jack sent some questions through looking at, robotics and AI integration and how that's going to hopefully a lot of the things they're working on are really about improving accuracy, particularly of alignment. Um, but actually, is there evidence that shows that if you get the alignment better, the 2, the 5, the 10-year follow up is better, or is some level of, I would say, the artistic side of surgery actually still able to get good outcomes?
So I missed a bit of that because it cut out, but essentially, is there that do the does the artistry of surgery still marry up with good outcomes, essentially?
Yeah, and basically, is there really strong evidence that maximizing alignment, for instance, is going to make the biggest difference, or is it okay to still have, people using their techniques that maybe not necessarily be perfect, but they do still get good outcomes?
Mm. Yeah, I mean, that's really the question at the moment and the question around robotics, because that's the sexy new modern thing. But and that's been used now as a mainstay, I think, for knee surgery. And I think patients hear about robotic surgery and does it make a huge difference? And looking at the literature a couple of years ago, there are actually 15-year and 20-year follow-up studies looking at the outcomes. And while it definitely does improve the precision in terms of the degree accuracy, I think it's 1 to 2 degrees more accurate in
Mm,
terms of correcting the alignment, the outcomes were no different.
yeah, that's what I'd
And
heard.
that's what we have at the moment.
Mm,
Yeah, the outcomes are no different, which is interesting. And I think while we're looking at outcomes, that is the most important thing. Uh, and generally, when we look towards doing an operation, we generally go to putting back to what it is normally. And that's generally a good way to do it. But the knee is such a complex joint. It not only does it flex and extend, it does some rotation as it goes through its range of motion. And we don't have the right sort of implants to put in to recreate that motion accurately.
Mm.
And I think that's one of the reasons why 20% of knee replacements, no matter how well you do from the planning, still have some element of pain and unhappiness.
mm,
And looking a bit deeper to why those people are unhappy, I think what we need to try and figure out. And there is a group in Sydney actually that started bringing up a classification called the CPAC classification. It's pretty much looking at the limb alignment versus the joint alignment. And they have, I think, about 5 or 6 different configurations. And they are stipulating that for certain configurations, a one type of operation is better, and for another alignment, potentially doing a more traditional or other sort of way of doing that knee replacement is acceptable. And potentially finding those patients who are suitable for one or the other could be the way going forward. Because at the moment, while there's more interesting technology that we're applying, it's not really making a huge difference at this current stage.
mm,
Yeah, actually, with that in mind, I was just thinking about when you get a joint replacement, and I guess this could apply to hip, knee, or ankle, is we could think about what is the best or optimal alignment of the lower limb in each joint. But do you actually want to create, if you, for instance, give someone a joint replacement, do you actually want to change the orientation of their joint to what it was, thinking that that's more optimal
Mm.
or normal? Or if someone does have a little bit of, say, genu valgus, or they've got tibial variant, which influences the angle of the ankle or the knee, do you want to keep it within that same orientation, or do you actually want to change it?
Yeah, so that's the big question at the moment. You hit the nail on the head. That's the argument between, you might have heard about it already, about mechanical versus kinematic alignment of the knee. And at the moment, traditionally we've been doing mechanical alignment because from a longevity of an implant point of view, if the joint line is parallel to the ground, technically there'll be less shear forces across the polyethylene or the plastic. So it should wear down less and the joint should last for longer. But we're leaning towards more research looking at kinematic knees, because patients who have been walking their whole life with their knee in a little bit of bow-leggedness or knock-kneedness with some joint line angulation, perhaps they're not happy because they're not restoring that way they've been walking for 60, 70, 80 years of their life. So that's where the research is looking at the moment. And there hasn't been any proven way of what's better yet, but that's certainly the question that's being asked. And it'll be interesting to see in the next few years how that performs and how it goes.
Yeah, because the thing I think of straight away is you have had decades of building up the myofascial system in a particular way to withstand certain forces in different planes, and that do you want to change the joint alignment, which is then going to change tension distributed through the soft tissue system that may not actually be adapted and designed for that individual?
Exactly, exactly. So traditionally, when we were doing sort of just making a cut to make it flat, we weren't respecting the soft tissues as much. And we were doing releases of certain soft tissue structures to try and get that knee balanced.
Mm.
But more and more research I think we're going through now is showing that trying to respect those soft tissues and maintain those tensions is what will make the knee happier. So I think, yeah, going forward, putting more of an emphasis on looking at the whole knee rather than just the bone, because that's orthopedic surgeons tend to do. And that will, I think, give us better outcomes potentially. I mean, that's what we're looking at, given that the technology so far hasn't worked in terms of just doing a mechanical bone cut. But I think, yeah, more respect needs to be go to the soft tissues.
Mm. You're So at the moment, we're going
Because you
through quite
mentioned
a
the
revolution when we think
myofascial.
about technology, and this obviously influences things like AI, robotics. It's all the things that you hear about these days. Are you noticing that this is having an influence in what you're doing? And do you see in the future what you do is going to change rapidly in terms of the procedures you perform? Like, do you think we get to a point where we don't need to do joint replacements because we'll have some other therapies that can regenerate tissue like cartilage? Or do you think that this is some still quite early on and overhyped?
Yeah, I mean, I think it's still early on, but I think at the rate we're progressing, we will get there at some point. And we'll get to a point, I think, in the future where we're able to recreate chondrocytes and get cartilage to be replaced without doing surgeries. But I don't know if it's going to be within my lifetime. But
Mm.
there certainly is a lot of research going into that area. I remember even 10 years ago, I was doing research at St. Vincent's looking at trying to get cartilage into an injectable form and trying to put it into a 3D printing gel. And we found that most of the cells would die and it wouldn't really work. But they were trying to make it a cartilage pen where you'd open up the knee and paint in the defects and
Yeah, it's funny you
hopefully
say
get the
that. I
cartilage
actually
to take
I
growth.
caught up with Claudia DeBella recently to
Ah,
chat.
yes, yes.
Do you know Claudia?
Yeah, I worked with her over there in the department, correct.
Yeah, I caught up with her to talk about this concept because obviously they're trialing more and more of this technology they've been building for a long time. Um, but one of the
Mm,
discussions that keeps going back and forth, and it's something that you might be able to elaborate on more, given my lack of understanding, but is there keeps being this idea that if they are able to implement these sort of scaffold structures, it's usually within a hydrogel and it's some sort of collagen structure, and they try and implant these chondrocytes. The thing that, and I asked her this, but she was sort of unsure of where this would go, is clearly with all biological tissues, typically you need some sort of mechanical stress in order to actually have those tissues actually do something. And one of the questions that I had for her, which she didn't really necessarily have a protocol that was in place, but was I always find it very interesting whenever they do any sort of chondral repair or chondral injection or some sort of surgery to assist with that. They basically tell people to do nothing or no load bearing on that joint for weeks on end. And I found that really interesting because to me,
mm.
that's the complete opposite signal that the chondrocytes probably want in order to actually stay alive.
Yeah, yeah. It's a difficult problem, and it's something we're seeing a lot of in terms of doing cartilage. Just even now, with our more limited ability of doing cartilage replacement, in terms of our synthetic implants and fibrogels that we use sometimes, is that balancing that mechanical stimulus with the actual physical ability to get something to stick into a wet environment where it's very hard to get something to adhere. So inside the joint, it's filled with the synovial fluid. You have to make sure it's dry, and trying to get this goopy stuff to stay in one place is very difficult. And the only way to do that, we find, is just to keep the joint locked and keep them non-weight bearing. But then, like you said, you're not really promoting that mechanical stimulus to try and allow it to then react to that stimulus and then grow and adhere to that defect. I think as we get some implants or some solutions or some, I guess, the actual binding agent that allows us to stabilize it further, if that becomes more, I guess, less friable and has the ability to stay in the place we want it, we would hopefully be aiming to do more weight bearing to try and get all the factors going in the right direction. But at this stage, I've seen, like, once you bend the knee or move the ankle joint, you see this goop just pour out into the areas it's not meant to be, which is just the physical nature of it at the stage we're at.
Mm. Do you think that
Which is
that
why cartilage treatment is so hard.
Do you think that that's actually a limitation? Is that maybe it's the wrong approach? Like, I know that and it's probably something
Yeah.
maybe you don't want to comment on, but they've spent lots and lots of time,
Mm.
money, and research. And to me, on the surface, and this is a completely naive position, but it just seems like that's never going to work.
Yeah, I can understand what you're saying. I mean, the thing is, in terms of the one I'm talking about now, that one where you're injecting some fluid into that area, it's not covered by MBS, so it doesn't have good amount of studies to support its use
Mm,
yet. But from colleagues and talking about anecdotal research, it seems to show a reasonable result. The other options where we take plugs of cartilage from one part of the body going to another part of the body, that also has a variable efficacy in terms of helping that joint regenerate. But even for the ankle now, the only evidence we have is for microfracture. And
mm,
that's when we just go into the area where there's no cartilage, just break it down and help blood flow come out. And even at the end of the case, you see it's filled up with a bloody clot with all those good nutrients needed to promote a fibrocartilage synthesis. And that's what we've got so far, which is working reasonably well. But I think we're at that stage where we're throwing all this money at cartilage synthesis because we don't have any good options yet. So
yeah.
everyone's trying to figure out something, and there's always a bit of leakage, or a lot of leakage, when you're trying to get to something that will save, in the end, the patient a lot of pain and angst.
Mm.
At the moment, with some of the technological changes that are happening, is that influencing what you do at all clinically with regards to how you perform certain surgeries or how you use robotics to assist what you do when performing surgery?
Yeah, I mean, in terms of foot and ankle, it hasn't really been used much, I think, for foot and ankle as opposed to hip and knee. I think where it might be used is for alignment of total ankle replacements. And I think some companies are talking about that now. But I think from I guess it's a bit of a pragmatic point of view, there's just not as much of it, ankle arthritis and ankle pathology, for them to throw money at
Mm.
putting robotics into that area. Whereas for a hip and knee replacement, you're just going to be doing them all day. So it makes sense to have that technology go in that direction. In terms of technology for the foot, I mean, a lot of issues we've had in the past are due to wound problems and having wound breakdowns, infections, and we know that bigger wounds have higher rates of infections. And what I've found in my lifetime as a surgeon, now I've changed practice, is doing smaller incision bunion surgery. Again, it's not a huge change. It is making, instead of doing a large cut over the big toe, you're doing four smaller cuts, and otherwise, the metalware you put in is a few screws, and the outcomes are still the same for both at the moment. But that's something that we've changed because it seems to be non-inferior, but we are able to reduce the amount of soft tissue trauma we inflict upon the patient. Um, yeah, so in terms of technology, we're using X-rays to do that a bit more, but more in terms of AI and technology. From a pragmatic surgical day-to-day use, I'm not using it a whole lot, but I think where it has good utility, I think, is in surgical training, perhaps, because if you're trying to get young doctors to try and learn a complex procedure, the best way I do it, and most trainees do it, is from doing the operation. And if you can do this in a sort of virtual reality with an Oculus set of goggles, do that over and over a few times, you're much more comfortable coming into it. There's evidence to show that learning curves really are a thing, and the more you do something, the better you are at it. So if you're doing it more in a lab controlled environment, you have less potential iatrogenic harm done to patients. So I think from a training point of view, that's something in our current uh, next 5 years sort of thing. We'll see a lot more of that happening.
Mm.
But it's interesting. I mean, from a technology point of view, um, it's interesting to see where surgery is going to go. But in the foot, we're not using a whole lot of that AI or robotic at this point.
If there was a technological thing that could be solved for you, what would you like to see?
Mm.
If it was, like you're dreaming of someone coming up with a solution that at the moment you find difficult or annoying, what would you like to actually see? And it might be something small that maybe we don't even understand because it's an instrument or something. But is there something that you're really hoping someone solves through some sort of technological advance?
Yeah, I mean, there's a few things that do get a bit frustrating, and I think CRPS and pain perceptions are something that's very difficult to deal with, especially in the foot and ankle.
Can you actually,
And
just for our
despite,
listeners, can you elaborate on CRPS? Because it's something that, as you said, is
yeah,
common
sure, sorry.
enough, and people probably are not as aware that it can be a complication following something like surgery.
Yeah, no, very, very reasonable. So essentially, after surgery, especially, it can happen anywhere, but it happens more so in the foot and in the hand. After making the incisions and doing surgery, sometimes it's after injury, you get an abnormal response where your nerves pretty much overreact, and you get a lot of pains, which are generally described as a burning type pain. In certain nerve distributions, you can get some skin changes where it gets red and hot, and you lose hair, and your skin gets a bit glossy. And the exact reason why this happens is not well understood. The body hyperreacts and causes this, and it can cause chronic pain. So after minor surgeries or procedures, you can have many years of chronic pain, which you'll need to have a lot of different doctors coming in to help you with neurologists and pain specialists. And the way, at the moment, some ways we try to combat this is making sure I give all my patients vitamin C. There's been evidence to show that vitamin C can help prevent CRPS from coming on after doing surgery. And fortunately, I haven't had to manage a whole lot of it. But it's something that if we could understand these pain pathways and why it happens a bit more, it would be easier to manage and easier to prevent. And at this stage, we're leaning on, when it happens, getting both, I guess, the psychological side of the pain stimulus being managed, as well as the medical side of things with pain specialists doing potential nerve related procedures. And I
What?
think a lot of what we do doesn't take into consideration the mind and that's impact on the somatic, and how your sort of well-being and attitude going into certain things can affect your outcome. And I think that would be interesting to look at in the longer term as well.
You mentioned vitamin C. What is there a mechanism or mechanistic understanding of why that might help with reducing the prevalence of CRPS?
Yeah, good question. Unfortunately, I don't know myself how it actually works, and I'm not sure if it is actually well understood. But all we know is it does work for whatever reason.
Mm.
But I might have to do some more reading and look into it.
A question I want to ask you is about what the role of the retinaculum, because this is something I've been learning a lot about with this course I'm doing in Italy, where if you think about the retinaculum, there's very well formed retinaculum around the wrists, but also around the ankles. And traditionally, they have thought of
Mm.
being just simply thickenings of the deep fascia, so around the ankle of the crural fascia, that help to make sure that tendons stay in place. But some of the research that Carlos
Mm.
Deco has done has looked at the histology of the retinaculum and seen that they are highly innervated with sensory proprioceptive organs in particular, so like Ruffini and Pacini corpuscles. And they've speculated
Okay.
and hypothesized these ideas that they're very important as proprioceptive organs that are essentially monitoring tension of all the different myofascial chains around the ankle to help enforce or help provide signals to the brain to make sure that appropriate neuromuscular signals are created to help stabilize the joint. And I'm interested when you
Yes.
think from a surgical standpoint, is the retinaculum something that you actually look at? Do you actually see, or have you observed, say, damage to the retinaculum associated with things like chronic ankle instability, or do you actually pay attention to the retinaculum itself in any way when you're thinking about reconstructive surgery, or is this something that really isn't looked at?
Yeah, that's really interesting. I mean, I'm very excited to hear something like that because that's something that could potentially relate to some to conditions such as COPS if it's restricted mainly in the wrist and the hand. But
Mm,
essentially, when we deal with the retinaculum, I do come into contact with it and approach it surgically in direct approaches to the ankle. And oftentimes it's released to get access to those tendons at the front of the ankle, and
mm,
we repair it. In some cases, I've seen it not be repaired. And between those patients, I haven't seen much of a difference in terms of those patients having an abnormal pain response or difficulty rehabilitating. Um, but it is important, like you mentioned, to prevent bowstringing, and especially with the tibialis anterior, we make sure that we don't release much of its sheath and make sure it's under the retinaculum to prevent that bowstringing effect, which can be a bit, I guess, more irritating to the patient and preserving the function of that tendon.
mm.
But it certainly is something. When I see it, I try and repair it because I try and repair things when I can when I go into the ankle.
That brings up an interesting question because I've been talking to a number of the surgeons about the concept of repairing things and
Mm,
whether we're actually going down the right path by repairing something that has actually failed. And what I mean by that is
mm,
not that you wouldn't do something to try and solve whatever anatomical disparity that's occurred, but if you're
mm.
recreating the structure as it was created and it failed, what is the actual reason that we recreate something that potentially has the ability to fail in the same structure again? And the main thought that I've been having is, sometimes we recreate something that continuously fails, and there isn't a lot of discussion about maybe that's not the correct structure for that type of activity, and we should be thinking about reconstructive surgery being one in which we actually try to create a different type of structure.
Yeah, so like instead of just restoring the integrity of the structure, actually changing some of the structural properties of the tissue.
Yeah, and you see that. So, like, say for instance, the example, and I think you mentioned like a tendon transfer is probably an example, and even I always think of the Lateral approach that they take for, say, shoulder
Yes.
instability. It's a completely like they decide it's like, okay, well, this structure is just not working. It's just
Hmm.
it's not creating stability. Let's reconstruct this
Mm.
environment so that it actually is stable. And to me, that seems a very innovative and clever way to actually solve a problem that repairing or recreating what was there was not actually getting the solution that we wanted.
Yeah, I mean, definitely. There has been, I think, a lot of different, unique, and innovative procedures to try and address when certain traditional ways haven't worked. And I think an example would be sort of ankle lateral reconstructions. There were non anatomical ways where people were reconstructing them with the lateral peroneal tendons rather than doing a reconstruction and repairing the ligaments themselves, but that did have problems in terms of having lateral ankle issues and pain and mechanical issues. But in terms of the ankle, that's what I can sort of comment on in this situation.
Hmm.
Because we know that doing the repair of that structure causes it not to fail more in the future, that's why we tend to continue doing it. And by doing that, we prevent other things from failing. So if we were to continue having ankle sprains and inversion events, would be causing increased damage to the cartilage, which then would in turn cause that joint to fail and have a high risk of having arthritis in the future. And interestingly, when you brought up the lattice, I think that's a great innovation that was brought into mechanically actually putting a physical block with
Mm.
a non-anatomical structure to prevent the shoulder dislocation. I think that's actually a great surgical technique used. And we have a good sort of criteria with shoulder pathology to see when we do that versus doing an actual reconstruction. And now, when we get more and more evidence, more and more patients seen, we know which patients will do will do better with a lattier versus a traditional Bankart repair. And I think if we were to look at maybe some things that keep failing, we should be innovating and looking at more things. But I can't really think of any others in our current age where they do keep failing despite repairing them. Are
Well,
there many that you see yourself in practice that
yeah, the
at
one
the
that
moment
I've been trying to
don't cut
catch
you
up.
off it?
Yeah, the one I've been trying to talk to people about a lot is ACL. I think it's a shit solution that we've got at the moment. So
ACL.
yeah, it's a
Okay.
disaster. Like telling people you got 12 months recovery and the likelihood of you re-rupturing this is still pretty high, right? It's not a good
Still
solution.
high.
When we spoke with, I don't know if you know Julia Kirby at all. Like, she mentioned what you mentioned
Yeah,
around,
yeah, I heard hers. Yeah,
yeah. She mentioned,
I worked
chondral.
with it back in foot spray actually.
Yeah, fantastic.
Good times.
Yeah. Particularly, she mentioned chondral lesions. At the moment, particularly in the knee, we don't have great solutions for them. We're trying different things, as you said, but it's not really getting the solution we want. And I wanted to ask you, is there any of these pathologies in the ankle that you're like, no, we offer something, but it's not ideal, and you're still sort of having to go, oh, well, you're going to have these issues. Is there something like that for you with the ankle and foot that you're still, you do something to help them, but it's not a complete fix?
Yeah, I think one of the main ones again is the cartilage injury, the OCDs.
Yeah.
I haven't had enough of a longitudinal follow up of my patients to see how they do. But at the moment, we don't have a good way to actually, because while we do microfracture, it fills in with hyaline cartilage, but it's a fibrocartilage. So it's not as good quality as their normal cartilage. And if there's any sort of asymmetry to the cartilage, they're at higher risk of getting ongoing damage and issues with their cartilage and their joints. So that certainly isn't optimal. And I think there could be more research we can do to try and optimize that. Other than that, I guess the tendinopathies are also something that can be quite difficult to treat, like plantar fasciitis,
Mm.
insertional Achilles tendinopathy. Some people have chronic pains here, and despite trying the whole algorithm of approaching all the various allied health and surgical options and medical options, they don't get relief. And for those subset of patients, I think it'd be nice to have better options for them as well, and something that's a bit more a bit more prompt and a bit more, because at the moment a lot of these take months and months of trials of different therapies to see
Yeah, I
if they
agree.
work, and that's can be common to be 6 months to a year, and sometimes you see good results and sometimes you don't.
Mm. Yeah, no, I agree with that. That's definitely a frustration. You move people through that chain, but they still sometimes don't get great results. And everyone is sort of saying, well, this is the
Exactly.
best we've got at this point.
Um,
Yeah, that's right.
a question we like to ask our guests, Janan, to finish up is if there's anything that you do as a hobby, anything that you're currently learning about, or anything that you're interested outside of your professional work. It's always interesting to see what makes people tick outside of their work.
Yeah, I mean, at the moment I've got back into Brazilian jiu-jitsu.
Mm.
So I like martial arts. I've been doing that a lot of my life, but going into training, I've definitely neglected that, and I've really enjoyed getting back into that in some Muay Thai, and just using the mechanics and sort of, I feel like it's like chess of the body,
Mm.
trying to try different moves and different manipulations to try and get the desired position and failing multiple times, but it's great, and I think it's enjoyable getting back into that physical aspect.
We better not run into you down a dark alley.
It's funny the amount of times we ask people that question, they go, "Huh, time to do something outside of work. What are you talking about?" So it's good to hear that you make sure you do things outside of your work, which is I think important. What belt are
Yeah,
you?
definitely. I mean, I found like once Oh, I'm just like blue stripes
Mm.
for that. I did karate most of my life, and for that I got up to second dan black belt, and then from then, because I went to uni and it was just difficult to get to karate, I did jiu-jitsu for a few years, then went off and did training, and now starting it up again locally. And it's just awesome fun. It's great getting back into that sort of environment with fighters. They're very humble people. You're just getting at it and just having fun with each other. It's just awesome to do that again. And after finishing training and being able to go back to do some things for yourself, it's really, really lovely. And obviously, and also I've got a young family, my daughter, I spend a lot of time with. So
Mm.
having the ability to do that has been awesome. Really good.
Thank you very
Could I ask you a
much.
quick question actually about myofascial release?
Yeah,
By all
Is that
means,
okay?
go
go
for
for
it.
it.
Yeah. Because when you mentioned it yesterday, I was like, oh, this sounds interesting. Maybe I'll do a quick look at it. And I saw there was some systematic review on it in 2015. It showed it had good results, but I don't really know much about it. Is that something I can offer my patients when they have certain issues or ailments? Is it mainly
Mm.
directed towards high performance athletes, like the manipulation, massage, and traction, and all those sort of aspects?
No, not at all. I think we use it and apply it to all different types of population groups. When you use the term myofascial release, it can mean a lot of different types of manual therapy techniques. Um, and to be honest,
Okay.
like we employ different manual therapy techniques depending on what type of neurophysiological effect we're trying to induce, and obviously relevant to the patient in terms of whether we're trying to restore, say, tissue sliding mechanics, whether we're trying to improve range of movement, whether we're using that to alter things like muscle tone and sensory motor control. So yeah, no, I use it a lot. It's amazing to see how much myofascial problems are associated with a lot of conditions, even when a lot of the problem is more joint related and they develop, say, secondary myofascial changes associated with
Did,
that problem for a long period of time.
question for you,
Sure.
Janan. Did you have a look at like what the underlying discussion around the mechanistic, relation of what myofascial, issues are and what that is, or was it just more talking about the outcome of the method?
No, I was wanting to learn a little bit more about that from people who do it because there's
Mm.
such variability. I was just looking at what it actually means. So I wasn't sure what the actual
So I think, yeah,
um, practical
basically,
process was.
yeah. So essentially, and like I'm speaking for Jack here because my knowledge comes from him, but essentially, I think the thing that we all get taught, whether you're a physio, doctor, whatever it is, if you're relating in musculoskeletal health to, everyone gets taught about, say, joint synovial fluid and how that acts as a lubricant
Mm,
within the actual joint structures, or and it does other
yep.
things, nutrition, all sorts of different functions. It creates pressure in order to create that hydrostatic effect and all of those things. With the myofascial system, particularly, and when we say myofascial, we're talking about muscles and connective tissue structures, and fascia itself, which is, for most people who aren't aware, it's the connective tissue lining that goes around different compartments of tissue. It goes throughout the whole body, including obviously like our visceral systems, but also particularly our musculoskeletal system. And in between the layers of tissue,
Mm,
we have hyaluronan, right, like hyaluronic acid, and it acts very much in the same way that
mm,
synovial fluid acts. So it acts for a gliding
yes.
effect between these tissues, and the gliding might be small, it might be large. Jack can speak to that about the different layers, and there's superficial and a deep fascia, and there's connections between the skin and the fascial connection, and all that kind of stuff. But what ends up happening typically, if you don't move a hell of a lot or there's some sort of trauma sustained to an area, those layers can kind of get stuck to each other. And what happens is water comes out of that
Yep.
hyaluronic acid and it starts to crystallize. And that the
Mm,
crystalline behavior creates those, and they use the term densifications. And those densifications, typically if it's in a muscle
yeah,
tissue or within a myofascial tissue, it's what people will describe to as like, oh, I've got a knot. Like, oh, I've got a knot in my shoulder that's been causing all this pain. What that actually is a myofascial densification. And the underlying mechanism for what's happened there is you've got this crystallization of the hyaluronan. And what myofascial release is, and Jack can speak to this much more, but essentially applying particularly friction therapy tends to be the one where you're kind of getting those tissues to glide across each other with a level of pressure can actually start to not only break down those crystals, but get reabsorption of fluid into the hyaluronan and allow that gliding to start happening again. So that's actually what it is and what these things are. So on the surface, it sounds like a bit woo-woo because people are like, I've never heard of this. Like, what the hell are you talking about? But there are very clear,
Yeah.
histological and biochemical kind of things going on that relate to other parts of the body that people are aware of. Like I said, I think I always, when I try and talk to patients about it or I talk to other medical professionals, I always bring up synovial fluid because I'm like, it's a very similar kind of mechanistic behavior. One's happening in the joint, the other one's happening within the connective tissue structure. And you need to actually affect on that because...
I mean, it makes a lot of sense. And I think
Yeah.
keeping those layers being able to move makes a lot of sense in terms of keeping your function and your ability to move without pain optimally. But in terms of actually doing it pragmatically, is that physically allowing those layers to become lubricated through physical therapy? Is there any sort of fluid or saline or something you inject as an adjunct to that? Is it all physical?
So I know some docs and surgeons. I don't think in Australia. Actually, I think it's actually quite big in Japan. Use hyaluronidase
Yeah.
because one of the,
Yep.
as John was describing, this densification occurs when you have a self-aggregation of hyaluronan to itself instead of binding to water. So it becomes more viscous and you lose that lubricating property. So with doing typically like ultrasound guided injection of the hyaluronidase to get to the right layer, you break down hyaluronan, so then it's not binding to itself. There are cells within the fascia called fasciocytes that then will secrete hyaluronan in a normal amount that will bind to water and then restore those gliding mechanics. So yeah, and I know they've also done some work of looking at shockwave therapy too, which I don't know the specific. I don't know enough about shockwave therapy in terms of the mechanism,
yeah.
but it seems to have some effect as well. So there are some different modalities that have been trialed with, at least clinically speaking, some good effect. I don't know how much research has been done on the hyaluronidase injection specifically.
But the thing that I think is really relevant for you, Janan, is particularly if you have follow-up with patients, one of the things, say, and I'm sure you get this, where everything seems to have gone really well, but the patient's still reporting a level of pain. Typically, we find when they end up with us, because we're doing the rehab stuff with them, we end up doing a lot of this kind of, and for practitioners who've done general manual therapy treatment, they might have just been working over the muscle tissue and thinking, I'm doing this. But typically we find there's a lot of ongoing sort of persistent muscle or myofascial pain that happens particularly post-surgery because you've actually disrupted those layers of tissue and they do actually bind to each other. And so getting that moving again, all of a sudden pain perception changes, all of these, and there's lots of different mechanisms behind that, but we do see significant change and like, that actually feels a lot more comfortable, and it's usually quite a small application of manual therapy. It might be like 3 to 5 minutes, and they're like, that feels so much better.
Well, and actually, it made me think of a point you made before, Janan, about the incidence of people, say, post total knee joint replacement who have ongoing pain. Because the thing I think of is, well, clearly it's not coming from the joint because there's no joint left, but some of the secondary changes that happen within the myofascial system. And interestingly, I was reading a study recently looking at changes within the iliotibial band in people who develop hip osteoarthritis, and that you see an increase in stiffness and a reduction in gliding within the sublayers of the ITB associated with hip pain and pathology. And so you typically see this, like John mentioned, like post-surgery around some of the scar from some of the surgical incisions, like around the retinaculum of the joint, or even as a secondary problem that's developed over time to have had long-term knee pain and then some dysfunction and changes in their myofascial system, that can be a component to their pain that persists even following, say, joint replacement.
Well, to give you an actual example, because it happened really recently to me, I had a patient who had meniscal surgery, and he said to me, I'm getting, like, most things are reasonably comfortable, but I'm getting a lot of pain when I fully extend my knee. And it's just right over, he said it's quite sharp, but it's diffuse, it's across like the anterior aspect, sort of over the top of my kneecap. And I said, okay, like, he goes, it doesn't feel like it's in the joint, but it really hurts. I said, okay, and I'm having a feel around his quad, and all of a sudden there's this really dense spot, basically like right in the center of his quad. And I just kind of got into it a little bit with some friction for about 3 minutes. And then he got up and he's moving around and he's like, the pain's gone. He goes, it's been annoying the crap out of me for like the last week because I can't.
Oh, that's great.
Yeah. And like, you pretend like you're a
That's
magician. And
It's funny you mentioned that because I have a patient. So I got a patient just like that. Maybe I ought to send them your way because it
Yeah.
just has that sort of weird sort of knot or pain in the anteromedial quad after a meniscus
Yep.
debridement.
I
So
wouldn't be
certainly could be
surprised.
a
I'm not
reason.
saying it definitely is,
But
but I
just
wouldn't
like
be
you said,
surprised if it was some sort of myofascial pain.
Particularly with
yeah,
those sort
I
of
mean, an
diffuse,
avenue to look at.
non-specific problems, it's very, very common.
Mm. Mm. Yeah, that makes sense. I think the problem is we have a lot of those issues post-operatively because we immobilize our patients for way too long. I think 6 weeks is traditional for keeping people in a plaster or in a boot, non-weight bearing for a lot of conditions. And I found, especially going overseas, going to Japan and the UK, they tend to mobilize people within the first few days.
Mm.
And I'm trying to do that now with most of my patients, and I'm finding I think that will make a big difference, especially
Massively.
like you're saying with keeping
Yeah, definitely.
those planes lubricated and moving.
Well, I even think too, just from
Because I think
I was just going to say, Jen, like I even think of from the standpoint of regulating the local tissue environment, because one of the issues you get, say, with immobilization is that interstitial inflammatory stasis, where you get an accumulation of inflammatory byproducts from the pathology or the surgery without adequate mobilization. You're not getting that clearance within the local tissue.
yes,
Mm.
exactly.
Mm.
Not that they're getting that flow and that blood return and getting the bad humors away. No, completely agree.
Yeah,
Very
yeah.
interesting.
Mm.
Janan, I don't think we can thank you enough for your time. We apologize for some of the technical difficulties earlier, and we really appreciate you coming and sharing your knowledge with us.
My pleasure. Thanks so much for having me on. It's been a fun discussion.
And I was
Look
just
forward to catching up maybe another time.
Yeah, and actually, if people want to find out more about you, Janan, where should they find you? Where can they find you?
I guess they can go to my website if they're interested. It's cogsurgery.com.au, and it has a bit of patient information if they want to learn a little bit more about foot and ankle stuff. And yeah, I guess that'd be the main avenue. But I'm always happy to chat to anyone about if they have questions about foot and ankle or orthopedic stuff.
Beautiful.
Right. Well, thank you
Thank you
very
so
much.
Pleasure. Have a good one.
All right.